nursing students? Time to talk. Welcome to the Real Talk School of Nursing Podcast, Season 4, Episode 9. I am your good and faithful host, Michael Smith. Thank you for continuing to subscribe to the show. You can support the show directly on our Patreon account at www.patreon.com/realtalknursing. And for less than a quad long shot grande in a venti cup, half calf, double cup, no sleeve, salted caramel mocha latte with 2 pumps of vanilla, substitute 2 pumps of white chocolate mocha for mocha, and substitute 2 pumps of hazelnut for toffee nut, half whole milk and half breve with no whipped cream, extra hot, extra foam, extra caramel drizzle, extra salt, add a scoop of vanilla bean powder with light ice, well stirred, and you can gain patron benefits such as early content, shoutouts, and special swag. Write into the show at realtalknursing@gmail.com or use Facebook Messenger or contact us through Instagram or Twitter to share your experiences, ask questions, and give feedback. Thank you for supporting our friends, affiliates, and sponsors. Thank you to everyone who started following us on Instagram, Twitter, and Facebook. More listeners means more and better shows. Make sure to listen to the show and share the show with classmates and especially underclassmen and cohorts. Let's give a hand up to those who are coming behind us and welcome them into our community of fun, engaged, and supportive nursing students and nurses. Don't forget to reach out and tell us if you have any announcements for graduations, good grades, difficult tests, friends you want to help congratulate, and your announcement will be featured on the show. If you like the show, the Real Talk School of Nursing podcast is available on iTunes, Google Play, iHeartRadio, Libsyn Web Player, Stitcher, YouTube, Spotify, and SoundCloud. So, go to wherever you download podcasts, subscribe, rate us, review us, write into the show, and smash that subscribe button. Remember to leave only 5-star reviews because that's the only ratings that count to get us noticed by more nursing students. I want you to be part of this crazy nursing school journey. Patience. What is that? Who even has time for that? PIE is P-I-E. Patience in everything. It's a simple yet difficult, yet powerful thing to learn. Think about the last time you were impatient. What came of it? How patient am I with others? How patient am I with myself? How patient and kind am I with the trials and unexpected turns in life? Am I patient and fully aware of the blessings of each day? I've been given a gift, be it fruit or life. It's up to me to choose how to use it. This is a book of short essays on life through something as simple as pie. Here's Coletta reading Piology 101.
Piology 101, the synchronicity of pie in life. How awesome to ponder how our Creator has put our individual ingredients so carefully together. Yet we get to choose our finishing touches and the temperature settings of the day. Sometimes we're hot, sometimes we're not. Every day is spent forming our own creation of self. Some days we also form a pie. Our ingredients of the day can be mixed up, nutty, and complicated, or just sweetly simple. Fruits grown out of even the best soil and conditions may become bruised, but even imperfect fruit can become a pie to savor. Life, as imperfect as it may be, has a multitude of savory and sweet bites in each new day. Pie in life, filled to the brim with the fillings of our choice, oozing and bubbling over, and just so beautifully messy. Pie in life, any pie or day can end in failure and be perfected on the next. Pie in life, presented in pieces and are just what is left over, or sometimes well presented, well-rounded as a whole. Pie in life are made up of a beautiful variety of spices and different tastes. Pie in life, overworking can make it too tough. Pie in life, tender care will always produce a perfect foundation. Pie in life, dig in while it's fresh. Share that creation.
Get your copy of The Pie Letters by Coletta Hewitt in softcover or ebook from thepieletters.com. That's thepieletters.com, and buy your copy in softcover or ebook from thepieletters.com, or you can go to Amazon. Love you all. God bless.
to the Real Talk School of Nursing podcast.
Okay, so all right, so you worked as a PCA.
Yep.
And you were at a small hospital.
Yep.
And we work as nurses at a big hospital.
Completely opposite experience.
So how did things change? How did things change for you in the transition between those two environments?
That's a good question. So, I know I mentioned that I started as a PCA on a med tele floor. I eventually actually moved down to the ED after probably the first year and a half, and got good experience there. And that's where I decided, like, this is what I want to do. Like, I'm all about ER life. I love seeing all the people that come in and all the crazy things that we get to see.
One of which we are not going to talk about that we were talking about in the break.
Yep. Use your imagination. So
there's been a lot of videos on it lately for some reason.
Yeah, no kidding. So yeah, I got to see a lot of different things. And
I'm sorry. I don't know how that got there. I'm sorry.
Yes,
Keep going.
You do.
Keep going.
You know.
Keep going.
So, I gotta... I'm totally lost my train of thought all of a sudden. Worked in the ED, got to see lots of fun things, and that's where I knew that I wanted to be as a nurse. So, like, my responsibilities as an ED tech were, like, obviously I did lots of EKGs, so many EKGs. We weren't allowed to do phlebotomy, which I was kind of bummed about. But
yeah, that sucks. That was one of the things, because I think so my hospital that I worked at and the hospital that we work at now are the only place where techs do blood draws.
Oh, really?
Yeah, even within our system.
Oh, okay.
Well, and so I felt really lucky. Yeah, I felt really lucky that I got that experience.
Our hospital was my southern hospital was fortunate enough during, I think, up until 11 or 1, and I can't remember exactly, they were like a swing shift, but we had an actual in-house phlebotomist, and all they did was go around and do straight sticks. Yeah. They were also cross-trained as techs as well, so some days they were techs, some days they were phlebotomists, and even then sometimes they would even just go do tech work even if they were phlebotomy. But I digress. My scope of practice was EKGs, ADLs, and we actually did Foleys, which I thought was super beneficial because I remember in nursing school watching some of my classmates just kind of struggle with, like, the sterile procedure and everything, and we go to do the checkoffs, and I'm like, just coming to me second nature, and I was done, and my teacher looks at me and goes, "Nice." And then I get someone standing behind me a couple of thousand times. So then we get I get the
sometimes I throw a Foley in somebody who doesn't need it just to get practice.
Oh god. Yeah, could you imagine? That would be terrible. Although it's always fun to use the well, if you can't give me a urine sample, I'm gonna have to get it one way or another. Magically, we can walk to the bathroom and get a sample. Now, was that so hard? Did I really have to use that painful threat? But
it's a very mild threat. We're not threatening people.
No, not at all. Never a real threat.
Ever.
So yeah, that was it was a great opportunity to use those skills, and because ED's got all the tele monitors, so I had tele experience as well, so I was a tele tech too. I'd sit and look at the monitors and be like, oh yeah, that's not good, or even helping some of our nurses were doing like their ACLS research, and they were looking at rhythms, and I was going through and helping them with that even. Because,
you see them.
That's all I did for a 12-hour shift was stare at heart monitors. And every 4 hours we documented, we actually had the calipers out, and we had to measure everything.
Oh, jeez.
Yeah. So I got
it was very tedious.
But
that way too meticulous for me.
But it was a good experience. I got to learn a lot about rhythms and seeing different things and when to hit the oh crap button. So I felt like those, yeah, exactly. Please go check on them. They're not doing the thing they were doing a minute ago. So so I used all those experiences and brought them into the classroom with, you know, with a grain of salt. You know, obviously it's not textbook perfect, but it is enough where I understand the process of how to do all that stuff. I even used the opportunity on our slower nights to sit and talk with the nurses if I was studying and be like, hey, can you tell me a little bit about this? What do you know, kind of thing. And they were great. We were a small hospital, like I said, small department. I think at night we had 3 techs, and one of us was rotating as like the unit clerk.
Yep.
A charge nurse, 4 nurses, and a triage nurse, and that was it, and 1 doctor. So like it wasn't huge, but when it was slow, we were, you know, we were a tight family.
Mm-hmm.
Like everyone, we did potlucks all the time. God, everyone loves a potluck, right? It's your birthday. Oh, gotta give a big shout out to Miss Nancy and her cheesecake. It's like crack, legit crack. Like she'll bring it in for someone's birthday and it's gone instantly. Love her to death.
Shout out to Nancy.
Yeah, shout out to Miss Nancy. So
And yo,
So, yeah.
cheesecake.
and a cheesecake.
That joke that joke that I just made will make sense later this month. Just wait for it.
So awesome.
Matt knows about it.
So awesome. Yeah. So. Yeah,
So
that's kind
so
of that.
what's it like? I think every new grad nurse is going to go through culture shock, and I don't think it matters if you're at a big hospital or a little hospital.
Mm-hmm.
But for me, there was quite a lot of culture shock between the slower nature of working at a small hospital as a tech and just being the high volume, high acuity patients that we see in our major care section at our current hospital was shocking.
To say the
But it
least,
was,
right?
but yeah, I mean, it felt like there was a lot of, and I don't mean just culture shock, but it was like job shock, culture shock.
Mm-hmm.
Like, I know that I'm not alone. I know that I'm not alone, like feeling completely overwhelmed.
Oh, absolutely.
Like and that's the things, like I come onto this and the podcast, and it's a really good tool for me to like process things.
Mm-hmm.
And so I've had a lot of time to
Processing is
think about and kind of prepare myself for that kind of thing. And I remember in the first couple of days, I'm like, I can really see how somebody could get really overwhelmed by this job. I can really understand burnout. You know, I can really
totally.
understand how people would just be like, oh my God, get me out of here.
Uh-huh.
You know, I'm gonna go work same day surgery or something like that, you know, after a couple of years. But I mean, I can totally get it. Like, what was the transition like for you? What was the first, I don't know, I want to just say orientation, but what was orientation like for you?
It was a good experience. I had, because like I said, I worked both the day night shift kind of thing, so I had multiple preceptors. My day shift preceptor, because I did mostly day shift, I think they were supposed to do like 2 weeks of one, 2 weeks of the other, but ended up being like a month of one and 3 days of the other.
Yeah.
And it was mostly day shift. My day shift preceptor, super smart, loved her. She a little on the helicopter-y side, but at the same time, she wanted to make sure that I wasn't doing something I wasn't supposed to be doing.
Mm-hmm.
You know, she wanted to make sure I was being safe. Totally had trust in me, but still.
Yep.
Even my second preceptor, she was kind of like the opposite. She was like, "You got this, dude. If you need anything, just give me a shout."
Well, but I think that comes from I think from them trusting that you know enough.
Absolutely.
That you know enough to ask questions,
Mm-hmm.
and that you and that you have enough. How do I say this? That you you have enough confidence to say I don't know.
Right.
I need, like, I don't know this.
Right.
Because I feel like
You're strong enough to say help.
Strong enough to, there we go. I like that better, because
Yeah.
I think that does take a lot of strength that we have. We've had other people write into the program about that being an issue. Like, they feel like they need to be perfect.
Mm-hmm.
And I mean,
You can't be.
And you can't be. Number one, it's impossible.
Yep.
But I think nursing school kind of encourages that to a certain extent, like, because you have to be perfect in nursing school, otherwise the fear of getting kicked out.
Oh yeah.
So I feel like that's a byproduct of that.
Mm-hmm.
But I also feel like you just have to be able to say, I don't know. I don't know how else you could say that.
Absolutely. And then there's no shame in it either. Like, if you can't do something, or if you don't know something, ask for help. 9 times out of 10, someone is gonna be there to help you. Like,
and if they know the answer,
especially on our night shift, we're all about helping each other.
Yeah, I agree.
But as for like you're saying, kind of like the culture shock from going from like tech to nurse, right?
Tech to nurse, yeah.
So when I was a tech, I used to see some of the nurses I work with that would just get frustrated or angry, be like, I caught another patient, I just got rid of someone. I'm like, you're at work, what'd you expect?
Yeah.
I kind of still have that mindset.
I still feel like that way.
But at the same time, I totally get the whole like feeling burnt out and be like, I just need a second, please.
Yeah.
Especially like with our department, it's like you feel like as soon as you get one out, you've got another one.
Yeah.
Right behind you.
I haven't even gotten the dirty sheets off the bed, and you guys are already walking down the hall with the next one.
Yeah. So, yeah. I mean, that was the biggest culture shock, is finally just getting into that role and going, I totally get where you're coming from now. And feeling kind of like a jerk for thinking otherwise. But like I said, it's the job. It's something that you should expect. And I've actually personally been coming to that realization the last couple of weeks, coming into work. Yeah, we're busy. Shock. We're in an emergency department. Like, suck it up, Buttercup. Get to work. So,
you learned something from your mom.
Yes, I did. I have learned lots of things from her, actually. Both of them, really. But, so yeah, that was the biggest culture shock. As for like the population between the two places, everyone's sick. Everyone's got diabetes. Everyone's got CHF. Everyone's got COPD. It's, shortness of breath, chest pain, abdomen pain, you name it. I've seen it at both places, an equal amount. So, I think what we actually, and maybe it's just because of our location, I think we see more like alcohol and drug related problems and more mental health versus.
Yeah, we do see a lot of mental health where we are.
Yeah, I mean, we were just talking about that even.
I had a lot of ETOH withdrawal this past couple weeks.
Yeah.
And I was like, why? Like, and then I started going,
Valentine's Day was like a month ago.
Yeah, but honestly, we were talking a little bit off air about how some of the environment, the patient load coming in has been very full moonish. Yeah. And we're nowhere near a full moon right now. I mean, we were like halfway between the cycle. And that's what I was thinking. It was like it's warming up, but not enough that people feel good because it's springtime, they're getting sunshine. Yep. And they're like desperate for spring, and it still feels like winter outside. I'm like, okay, I can understand that. Yep. I don't understand all the ETOH withdrawal though.
Like I said, we didn't get a whole lot of that. It felt like, and maybe I didn't, or maybe we didn't. I just wasn't paying enough attention to it. But it's definitely a significant amount, because we get a lot of the 1-to-1 situations where people need to be closely watched. Especially, like, my hospital clearly didn't have a mental health unit. So if someone came in with suicidal ideations, we stuck a tech outside of a regular ED room and said, all right, do 15-minute checks. And that sucked because that took away a tech position. So now the nurses have to pick up our job too. So, like I said, I think that was the biggest like patient-related cultural difference maybe, or regional difference. But
what about, so talk to me about your experience as like going through orientation.
Oh yeah.
We have because I would say that in our hospital, we have a fairly long, fairly comprehensive
The orientation process. Yeah, isn't it like 3 months or something like that, if I remember? Right?
I think the full thing is like 40 shifts.
Yeah,
But
that sounds about right.
in between all those, because I mean, 40 shifts shouldn't take as long. But you have a lot of education and other things in between it. So
Yeah,
it's
I think
lengthened
those
out
kind of
probably a month.
Yeah. So yeah, I mean, like I said before, my experience was pretty good, even with the day-night. My night preceptor, super awesome. I love working with her. I still love working with her. We laugh a lot. So I guess, I don't know, there was, especially when I was on day shift, I felt just so overwhelmed all the time because I was always a night shift person.
Mm-hmm.
So going from, a chill small ED at night to a point where like, hey, we have 0 patients for like an hour. How'd that happen? To, oh my God, everything's on fire. I don't know what to do. Was very overwhelming actually. And I remember meeting with,
and you're trying to learn charting, the nursing charting, and you're trying to not get lost on the unit.
And
I did so many extra laps on our unit.
Yeah, still
don't mind me, just taking another lap,
dude. I still ask like, hey, where do you find this? Because
yeah, it is weird that we have like I won't get into that, but we have like stuff that you commonly use. You have to go to the opposite end of the ER to go get. You're like, why is this way over here?
Right. But yeah, so, and I do remember talking to my preceptor and when we did like the halfway point meeting with the manager, and they said, oh, you're doing great, you're doing fine. And I'm going to kind of take this back to the one person you were talking about, how that went to dialysis and they were being told they were doing a great job on your last podcast.
Yeah.
I felt like that. So I kind of could relate to that, but not to a point where I felt like I needed to leave the profession. I think I just needed, like, kind of like you said, either a different shift, which I ended up applying for permanent nights and got it and have been significantly better since.
Well, I think more if you take some of the people who are on day shift now and put them on nights where we don't have the pharmacist on, for about half of the shift, and you don't have all of the resources, you don't have the supervisory staff, you don't have the manager there, you don't have a lot of the other resources within the hospital, they'd be completely overwhelmed by night, just like especially people who prefer nights,
Yeah. And don't get me wrong, I'm not knocking day shift whatsoever, because they go through a lot.
Oh, I agree.
They are always busy, and I mean, like I know from experience, not nearly as much as most of them, but they're hard workers, and I appreciate them too. But like I said, for me, it wasn't me. I wasn't happy. I remember coming home from work just defeated most days, and like, I mean, I still have that sometimes because it's the nature of the beast. But
it's the nature of the profession.
Yeah, but it's a little less than when I was working day shift.
What was talk about some of those overwhelming experiences, because there was one, and I think I talk about it in the show early, about having I had a patient come out of the stab room, and I was maybe 15 shifts in to orientation, so still trying to figure things out and still trying to put stuff together.
Yeah.
And patient came out of stab because our critical care rooms were just getting slammed. I mean, we were on divert, and it didn't matter. They just kept coming.
Yep.
And this we took the most stable patient out of our critical care rooms,
who was still not stable.
Who was not stable. They really should not have come out, but they put them with me and my preceptor, and they crashed.
Oh.
They crashed.
Oh.
And
that sucks.
And I'm like, I am in no way ready for that. And I had like, this preceptor is a throw them in the deep end kind of person. I think.
Sink or
Would
swim?
would you agree with that?
I don't know. It's hard to say.
I feel like he's a sink or swim kind of person, and he wants to.
It's like putting you through a test.
Yeah, but I agree with him wholeheartedly in that orientation is a very short amount of time that you have to learn a ton of stuff. And so you have to be like always on the edge of being overwhelmed.
Mm-hmm.
Maybe a couple steps overwhelmed. But but this was definitely one of those days that I think I will always remember. And I was just like, I can't.
Mm-hmm.
Like I don't know enough, and he basically had to take over the patient, and I saw that as a total failure on my part,
mm-hmm.
a total failure, and and
that's your inner perfectionist coming out then.
No, because I don't feel that way. I mean, I got down to the end of it, and I'm like,
maybe at the time.
Yeah,
but
I was just like, man, I am.
Mm-hmm.
And then I would have a couple of weeks with my other preceptor where everything's going smoothly, everything's going well.
I can totally relate to that.
He was pretty much leaving me alone. I would ask him questions, or he would come and he basically went into tech mode where he's just starting IVs and cleaning rooms for other people and helping them out.
2 of my 4 preceptors were like that.
And then, he's like, "You're doing fine," and da-da-da whatever, and we're all good, and we think you're ready. And then I would have 1 or 2 shifts where I'm like, "Oh my God, I'm so glad I'm still at orientation."
Right. I do have a similar situation that not quite crashed, but it was an extremely busy night. They were not. They didn't start in a stay room. They ended in one though.
Oh.
It ended up being septic shock. It came in with just mild shortness of breath. Ended up being intubated, kind of situation. Yeah, like ended up giving way too much fluid, and she was just everywhere. Ativan couldn't calm her down. Trying to rip her oxy mask off, couldn't get that to stay on, or the non-rebreather actually is what we had with her, and she just didn't understand that. No, that needs to stay on your face so you don't die. Please. And just gown everywhere, in the bed naked, and I'm like, no, please be decent. There was nothing. It got to a point where my preceptor, she's in there too helping, and it finally got to a point where I was like, okay, we need to fix this, and it's not going to happen in this room.
Yeah.
And I just still remember I spent so much time throughout the majority of my night in that room that I got so far behind on charting. Yeah. I barely even saw my other 2 patients who, weren't nearly as sick, but still needed my attention.
Still needed attention.
And just going home, I was walking out with my preceptor, and I was like, what happened? Is this my fault? Did I just screw up? And she's like, no, this was not your fault. You did fine. You were doing what you were supposed to do. And we talked for like a half an hour in the parking lot after the shift, and just kind of like debriefed with one another. And I found that really helpful too, is when you get a chance after your shift with your preceptor, just to sit down and talk to them and be like, these are the things that were good, these are the things that were bad, and let's next week or next time we work together, let's focus a little bit more on this, and let's try and see if we can see more patients that are like this, so you have a better understanding of the process.
And I felt
septic patients were the bane of my existence.
They're the bane of everybody's existence because there's so much stuff to do so fast.
Yes, and I've gotten significantly better at that.
Yeah, for sure. Yeah,
so I feel a lot more confident.
I'm amazed by how much less time it takes me to do stuff now, which I still feel like I'm like, oh, I need to be faster. I still feel that way. But yeah, you're always going to feel that way. But but I'm continually surprised. I'm like, okay, wow, I was not good.
You think back and be like,
wow,
right, yeah, okay.
God was watching over my patients at that time. Yep. But they, yeah. But I feel like, sorry, the debrief thing. There were a couple of times where I would have a debrief at the end of the shift, and they'd be like, "Well, how do you think this went?" And I'm like,
"Okay,
I can't even remember half the night."
Right.
You know, be like, you know,
hey, puberty.
but it'd be like, you know, like there's not even time to process it, and be like, "Well, this happened because I think this and this and this," and they were like, "No, that happened later on." And I'm like, then I don't know.
Yep.
I have no idea. And I almost suggest that if you are getting ready to go into orientation, or you're in orientation and you have a shift like this, give yourself time, or if your preceptor says, "Do you want to talk about what happened?"
Mm-hmm.
It's okay to say, maybe like, can we
do that next time?
Can we show up 15 minutes prior to the next shift together, so we can talk about this when,
well, that way you have a chance to process on your own.
Process a little bit,
like,
and you're not at the very end of your, you know, mental capacity, you know, because you're tired and you're strung out and all that kind of stuff. Like I really do suggest, like, maybe going, and then at the beginning of that shift saying, "Okay, what are 3 things that you want to see today, or for this shift, or things that you want to work out because of what happened in the last shift?"
Yep.
And then you're not being overwhelmed by, "I screwed up everything."
Yep.
You know, you can say, you know, "Can you walk me through bedside cardioversion process?
Yep.
Can you walk me through the paperwork? Can you walk me through, you know, I have to give these 3 medications IV push. Which one should I be giving first?" You know, like, well, we give this one because this one can sometimes make people feel nauseous, and so we give this one before this one, and you know, whatever.
Yep.
Like, you give this one slow because it can give people PVCs, you know, like that kind of stuff.
Right.
But that's easier, I think, to process at the beginning of a shift.
Wait, so
Then at the
don't
end.
push Dilaudid as fast as you can?
Well, you can.
I mean, obviously,
There's
that was
just a
not the PVC,
consequence
but,
for it.
Yeah. Weird.
Yeah, there's a couple of medications that I'm still kind of afraid of, and just one of them is Valium. That freaks me out.
Really?
It does, because no matter, I swear to God, no matter how slow I go, I mean, I could push that over 10 minutes, and I swear to God, like 5 minutes later,
On a syringe pump.
no, the sats will be like 84. I'm like, oh no, 77. Breathe.
Hey.
No, you're going in, like, I had to do this the other night, and it had everything to do with the fact that the person had poor circulation. Not because I
okay.
pushed it too fast, but
Okay.
they had poor circulation. They were like laying on their side, and they have sleep apnea.
So,
All 3 of those things, and they would dip down to like 77.
oops.
But they also had Valium on board, which didn't help.
Nope.
And I had to like do a sternal rub and be like, "Hey, wake up, you know, breathe."
Yep.
And then they
Or
did,
just
and
slap a nasal cannula on there real quick and
Oh
see
no,
if that
I
helps.
no.
Or if they're a mouth breather.
No,
you
they
know,
were
obviously.
they were already there.
Okay.
Yeah.
Oh, even with
Yeah.
oh gosh.
Yeah, it was like,
Oops.
no, but it was like, but I pushed, and it was a fairly small dose.
Yeah.
But I pushed it like because of other experiences that I had with that. I think I probably pushed it over 3-4 minutes.
Oh wow.
Because I'll take a syringe.
I could see where you would be a little gun shy on that.
And I'll fill up a full syringe. So because that was the other thing. That was a funny thing that I learned in my preceptorship while in school. That I learned differently in the ERs is, you know, you take a medication, let's say it's 1 or 2 mils or something like that, and you put it into a 10 mil syringe, a flush syringe.
Yep.
And because it's way easier to push that. Because what would happen is they would have an IV, and, you know, no fluids running because they have CHF or, you know, whatever the reason is.
Yeah.
And you'd sit there like an idiot and push 2 mils of medication really, really slow
Yep.
into their IV. Well, how many mils is the tubing? like 2 mils.
Yeah.
Like 2 mils. So you're just.
I know. I started thinking about that more recently.
So you could
too.
so you could push that as fast as you want and be like, it's not even in them yet, and then somebody would take the flush and go whoosh, like that.
See, that's where the problem comes. You have to do that part slow. Actually, that part's slow.
But that's one of the reasons. Like I put medication into a bigger syringe because it's easier to push a big syringe.
Yeah.
You know, versus the half mil of Dilaudid.
Like trying to just ease it on in there. Don't want you to, not stop, or don't want you to stop breathing or nothing like that.
Yeah.
And then follow the flush. Oops.
No, but they did that all the time, and how I had a student this week, who bled the bag, so they stuck the tube, they spiked the bag, and then took it back out, and was like squeezing, and then was squeezing the bag to get the air out, and I'm like, no, that's A, you're gonna spill something, B, you're exposing stuff, needlessly to air, and I mean, these things are both sterile already, so don't screw that up.
Yeah.
If you touch something else and we're like, all right, well, you might as well just throw it away, just to make sure. And
start over.
and she's like, huh, I didn't watch. Last time I watched somebody, they didn't do that, and I'm like, well, you're gonna do it this way from now on, please. Yeah. I mean, in a year, it makes so much difference. Mm-hmm. Here, let's take because we've been going for 30 minutes.
We have a lot to talk about.
But it's fun.
Yeah.
But it's fun.
Absolutely.
It's fun to look back on.
Yes.
It's fun to look back on.
Definitely.
So let's take a quick break, and then when we come back, we'll kind of finish up. We'll finish up talking about new grad experiences, and other tips and tricks from Michael and Matt. All right.
I've heard people say that too much of anything is not good for you. But I don't know about that. As many times as we've made food, and we've shared food, and we've made food, it just doesn't seem to me like it's enough. It's just not enough. It's just not enough, babe.
Okay, I won't subject you to any more of my singing if you go to foodiequeen.com. That's FOODIQUEEN.com and connect with Michelle Gray and join her Facebook group. There are almost 28,000 members, and you can start to see why when you look through her multitude of recipe samples in the group. Members share their successes and reach out for help and support in this great community, led by the foodie queen herself, Michelle Gray. Listen to Season 4, Episode 7 to listen to our interview. Good luck, have fun, and join her group. All right, so let's get out of kind of orientation and let's start talking about the first year, like the true. You're done. We're done with orientation, and we're
on your own now.
Now you are on your own, and
you
but
are
that's
the
the thing.
adult.
but that's that. I mean, but you're not on your own.
Oh no.
But you're not on your own, and there's so many, like, I feel like a lot of new grad nurses, especially the ones that have been writing in the past few weeks, mm-hmm. they do feel like that. You do feel like you're on your own, and I mean, the only thing that there are three things that I hear on our floor all the time. Mm-hmm. The ambulance line.
That never stops
ringing. The ambulance line, nurses who say things like, I learn something new every single day.
Yep.
Even the most experienced ones.
Yep.
And the third thing is that, and it was only after I did the show when I called it Nursing is a Team Sport.
Mm-hmm.
Then I started hearing it all the time. I was like, no, but you're never alone.
No.
There's Matt and I were just talking offline about a recent experience that I had, and another nurse came in because this patient needed so much in such a short amount of time, and it was, I mean, above and beyond what I think all of the things that you need to do for a septic patient, for example.
Oh yeah.
Where you have the.
I almost thought that's where you were going with it when you were talking about it.
No, but they needed so much more than that in such a short amount of time, because it really needed to happen in 15 minutes.
Uh-huh.
And another nurse came in, and she handled the IV. She handled. I grabbed the medication because I already had it, but she got the IV going, got IV fluids going, because I had like 3 other things I had to do, and just having her there to take that little piece away from me,
Yep.
I think is what saved the whole situation.
Absolutely. And it's not just
But
like
that's
and
every
nurses.
day.
Yeah. And that team though, it's not just nurses and nurses, it's your nurses and techs, nurses and EVS, nurses and doctors. Like, we all work together. Like, I know even with EVS, we've got a few of them.
I love
Dude,
our
they're
EVS.
like the coolest guys, man. Like, I always, whenever I see them, hey man, how's it going? Like, always talking to them. If I'm
because they are
cleaning a
going to
room-
pull our butts out of a fire and be like, look, this room is a disaster. I am so sorry. And they're like, because
Meh,
we're
I got
cool.
you.
No, but I think because we're, because we're friendly with them, because we respect what they do.
Absolutely.
I don't think there's any separation in my mind. I don't think there's any separation between them and me.
Right.
And it's really easy to kind of have this hierarchy, this rank structure. Like, there's doctors, then nurses, then techs, then
Whatever else.
then hucks, then blah blah blah
Yeah.
blah, and then EVS way down at the bottom for some reason. And I'm like, no, I'm pretty sure we're pretty much all at the same level, because
I wouldn't be able to do my job without everyone. Everyone. Hucks included. I didn't mention them before, but yes, Hucks are the unit coordinators. Or
clerks.
Clerks, not coordinators. Yeah, everyone helps play a role in making sure that things get done in a timely manner, or just makes things more efficient, basically.
But it's but in that first year, you're not alone. The point is you're not alone. And if you, I have not, I'm trying to think very hard about if I have run into any nurses in our department that were unwilling to help. Can you think of any?
On our shift? No.
And I'm not talking about like I don't have time right now,
Yeah.
I've got
Or
too much
just
stuff
like,
on my
no.
plate, but like, no, I'm not going to help you.
Yeah, no.
Has that ever happened to you?
No.
Because
No.
you're coming up on like a year and a half, 2 years,
Yeah.
right? Something like that.
About a year and a half.
Yeah.
Yeah, no, I've never had a problem. Usually it's, all right, yeah, let's go kind of
Yeah,
thing. And
right.
I know
Like-
I've been there too myself, where I'm like just kind of
I don't have
busy.
any more time than you do, but I can see that you need help, so let's get it done.
Yep.
And then you can help me with something right after. And the 2 thumbs up is my go-to, and be like, thank you.
Yep. The I scratch your back, you scratch my back kind of thing. Yeah.
But they have, so first off, so again, you're not alone in your first year, but
No.
but you are, but you do have that burden of responsibility, of primary responsibility. This is now your patient, and it's gonna be your fault.
You're the adult. You no longer can ask, I need an adult, because you are the adult.
Although every once in a while I do look around and be like, is there a more adulty adult around?
Yes, those are the doctors. I know I did that the other night. I'm like, I need an adult, and they're like, you are the adult. No, I needed a more adultier adult. Exactly. Okay then.
Gotcha.
Yeah.
Do you, even now, like, we work in a very high paced, high volume, high acuity hospital,
Mm-hmm.
and the pace sometimes can be overwhelming.
Yeah.
But so the point I'm trying to get to is that with all of that, it can take a long time to see enough where you're not seeing something for the first time every day.
Yeah.
You know, like the joke that I make is like, it's the experienced nurse who says, I learn something new every day, as in one thing new every day.
Yes.
Whereas like when you're in your first year or maybe year and a half or 2 years, you're like, I learn like 45 things every
Yup.
single day. But
and that's just in the first hour. No.
and I'm just too overwhelmed the rest of the day to even learn anything.
Exactly. No, I definitely think the first year is a huge amount of learning, and for me personally, I think I didn't feel like confident in myself until about that first year mark. It was almost like a light switch where it's just like, oh yeah, this is easy. I've done this like 100 times already. Why am I stressed over that? Oh well.
Like at this point, what are there still things that make you?
Oh yeah.
And I don't mean nervous, and I mean kind of
comfortable.
routine things, like stuff that is not crazy, not uncommon, but common stuff that you're still like not super confident in. You know what I mean? Is there still stuff?
Yeah, I mean, that comes more with just the lack of exposure to it. Like, every so often you'll get that one patient where it's like they've got some rare condition or whatever, and you're just like, I don't know. We'll let the doc come in and take a look, and they'll put some orders in, and I'll get you just stuff done. So,
well, like for example, we're talking.
Or actually, even
the triple lumen Foley is a great
I've yet
example.
to do one of those yet,
and I've done 2 of them in the last month.
Knocking on wood.
You're gonna have one tomorrow.
Don't tell me that. Not tomorrow.
But that's the thing, though. If you do, I will be on to. Well, no,
Do you
I
work
won't.
tomorrow?
No, I don't work tomorrow.
Oh,
I don't
lucky.
work tomorrow. I've got a class I'm going to, so I took a night off of work so I could go to this class. But
There you go.
But I'll be there all this weekend.
All right.
So if you need help, you can
got-
come to me. I got you.
And if you need help, you can come to me.
Yes.
Sweet. All right.
It's like-
see, we've got a thing already.
It's like nursing is a team sport.
weird.
Weird. and there's more than 2 teammates.
Exactly. And
The-
a whole department.
So when do you think? So you think it was about a year where you started to feel more comfortable?
More comfortable. Comfortable, confident, however you want to say
Comfortable-ish?
it. Comfortable-ish. Like I said, still every so often there's something where I'm just like, yeah, I don't know. And again, nursing is a team sport. I'll go talk to one of our coworkers and be like, hey, I got this going on. What do you think?
Mm-hmm.
And
Oh, I do
they've
that all the
probably
time.
seen it too, and they'll be like, oh yeah, I'd probably do this. Sweet.
I-
Or like
I-
you get
I
that
like-
one patient where it's like you don't quite know, should I start a line or should I just do a straight stick kind of thing? You run it by someone in their situation and they're like, yeah, I'd probably just do a line just to be on the safe side. All right, fine. What's the worst that happens? We don't use it and we take it out and they get discharged.
Yep. What's the
That's it.
consequence-free environment on that one?
Yep.
I do really like when I can go to a more experienced nurse and and they're like, huh, I have no idea. Let's go
Right.
look. Let's go. I love that. I love that.
If you're excited about this, then well, I'm definitely excited about this
Yeah, no
because if
kidding.
you don't even know, then
If you don't know, well,
see.
but I like that because it's a learning opportunity for both of us, and the advantage of having an experienced nursing staff isn't necessarily that they've seen everything, but they have a wide variety of experiences that can inform them on what they could be doing and
Right.
what they should be doing, or what they should, or sometimes more importantly, what they should not be doing.
Right.
Like, okay, whatever you do, do not do this.
Good to know. Thank you. Because I almost did that.
Literally almost did that before I came and got you.
Yep.
No. So tell me story time.
Story time.
Story time. Tell me about a first year, a new grad, because I want to end on a high note. So tell me about I'm not going to trigger you. I hope I'm not going to trigger you, but
Takes a lot.
tell me about a bad experience.
A bad experience?
A bad experience. And you know, maybe one that you didn't necessarily get anything out of at the time, but, you know, learns, you know, like, you know, now that I'm a little bit removed from the situation, it was valuable, but at the time completely overwhelmed, like bad experience.
That is a very tough question.
That's why I shared the show notes with you.
I know. I got to think about that for a second, because it's like, you know, you go through that whole like, oh, I've seen a lot of things.
I've seen a lot of things.
I've done a lot of things, and even the bad stuff starts to blend together. I will say I had one night. Actually, I got one for you.
There you go.
I had one night where I was in the row where we're right next to the monitors.
Ugh.
I
Those
dislike
three rooms. Those
so...
3 rooms. I always, with those 3 rooms, it's always the same things. Like, I always get 3 empty rooms all at the same time.
Yep.
And then just like, you're getting 2 ambulances and somebody out of stab.
Yep.
Dang it.
Yeah, after just discharging all of your patients at the same time. Because that seems to happen too sometimes. Like, there was one night where I'd fill up a room, discharge them all at the same time, and then it'd fill right back up again.
Yep.
And it's just
Yep.
like, all right, we're playing that game, I guess. All right.
I see how tonight's going to go.
Right. But I remember being in that row, and I had all 3 patients just needed so much, and I came into an already difficult situation, and so taking over a difficult situation can be very stressful too, because you're just like, dude, I don't even know where to start. So let me just read the notes real quick and go with the sickest one and start and work my way down.
It can also be stressful when you're on the other side of that too, when you're handing off to somebody and you're like
there's so much they're sick.
Yeah.
Read the note.
But it's like, but
I've done this, and this.
I hate handing off patients where it's just like, this is a complete crap show.
Mm-hmm.
And it's just like, that's the situation though. I have done my utmost best to hand you a good situation, everything tied up pretty with a bow.
Yep.
Not going to happen with these 3.
Nope.
Sorry,
exactly.
I'm very sorry. I had to do that the other day to the tall guy, the really tall guy with the curly mustache.
Oh yeah.
I was just like, I'm sorry, man. This is there's a lot of incomplete stuff here. I did as much as I could.
I'll fill in the blanks after we're done. But yeah, so I had one guy that was just like progressively getting worse. He ended up having like, I'm pretty sure if I remember right, it was like a pretty decent, not MI, but it was like end-stemming to the point where like they ended up tubing him. They had to take him out of stab. He ripped out his IV at one point, and he was already difficult as it was, so I had to get someone to come in and help me get another one of those. I had the patient next door to that who was pretty needy and also getting picked up to get transferred to another hospital because we were full. And then on the other side of that,
it's a whole nother discussion, isn't it?
Oh yeah,
we could have an hour-long conversation.
Yeah,
just with that.
I had another one, not as needy, but like still needy kind of thing. It's like,
and when he says needy, I don't think when you say needy, I don't think you mean like they're. They needed damage.
No, it's like she needed me to do stuff, and there was some of that in there
medically.
Too. But I could at least send like a tech or someone to go like, hey, can you just hit this real quick for me? Like, we're good, right?
Yeah.
Perfect. While I deal with this guy who's not doing very well at all. Like, I remember there was a point. The night went by so fast, and I actually ended up getting a low need that night, and I took it like that. They're like, you want to go home early? Yes.
Yes, I do.
Don't even ask me twice. I'm giving a report on. Actually, I think by the time I left, I had one patient anyways, so it wasn't that big of a deal. But I got to my car and I just sat there for like 10 minutes and didn't move, and just stared at like, what just happened? I don't even know how to comprehend. Even like
I can't
even
even
once they
drive
got,
right now.
Exactly.
I can't even drive right now.
Even when we got that patient back into the critical room, the doctor's like, "Dude, what's happening? What happened? What's going on?" Because it was a handoff patient, because the original doctor went home for the night and they signed out.
Yeah.
So they didn't really know, because the guy was supposed to go was supposed to be admitted. He was admitted, but he was supposed to go to the floor like, I don't know, like an hour or so.
2 hours ago.
Exactly.
5 hours
And it
ago.
wasn't until the transport aide came to get him, and I looked and I was like, this guy's not going anywhere right now, as you can see. And they're like, oh, okay. So we get him back into the critical room, and they're working on tubing him, and we're getting all this stuff, and I'm trying to like explain what happened. And even in my mind, I'm trying to stay as calm as possible. I'm just like, he was fine like 15 minutes ago, and out of nowhere, blood pressure's crapping out and he kept talking about, I gotta poop the whole time. So I got him a bedside commode, because he was able to at least get up to the commode a little bit, and was like hunched over, and like, so wasn't really getting good blood pressure readings to begin with. And by the time I actually finally got him back in the bed and got the blood pressure cuff on him, I was already like, this guy needs to move now. So I grabbed charge and I was like, I need help. Again,
Help!
It's not defeat. It's being strong enough to say, I need help. And at that point, I finally broke and said, yep, I need help now, please, and thank you. But I think that was probably, and it still is, probably the toughest shift I've had to date. Even compared to the one when I was during my preceptorship, because I at least had my preceptor to help back me up. I was by myself on this one.
Yeah.
So it's just, like I said, a row of very difficult patients that needed a lot.
Three.
Yep, and it's always those three, of course. Stupid.
We should just get rid of those 3 rooms.
Yeah. So then it can be inherited by another set of 3 rooms. But yeah, so that was my nightmare experience as a nurse, a year and a half out. And learned.
Was this?
This was like a couple weeks ago.
Oh, jeez.
Yeah.
So okay, so shift gears. What was a I don't know, like
the
a really
opposite
cool,
of that?
like the opposite of like a really cool experience.
Dude,
And
any one of my patients that leave with a smile, because like when I'm able to go in there,
we're not going for,
dude, I don't
Miss
care.
America. Come
Dude,
on.
No, I'm going with that.
As long as we go with a smile.
No, because like, so a lot of the times I can, like, if I'm not like overly busy like I would have been that night, getting a chance to sit and talk with someone while like I'm starting an IV, and we talk and I get to know them a little bit, and they tell me their story. I can do some anecdotal or material with them or whatever, and make jokes, and
Dad
we can
jokes.
have dad jokes. We have a good time, and then they smile and say, "Thank you so much. You were probably the nicest person I've ever had." Like I still remember several times being told, like, I've had so many people, and you're like the nicest. And one of them actually said the nicest male nurse they've ever had. And I'm like, oh, well, thank you so much. I'm glad I could make your experience that much better. And it's those kind of situations.
That's when you go, it's a good thing you didn't get Michael tonight.
Right.
He is pissed.
Yes. And I mean, like I said, we were talking about before, a smile goes a long way.
It does.
People can read you the second you walk into the room. Is this going to be a good nurse, or is this going to be a bad nurse? If you walk in and you look like you're just angry, or you're inconvenienced by their presence, they're going to pick up on that, and they're probably not going to feel the same way as if someone who comes in and you're like,
you're poisoning
hey,
the well a little bit.
Yeah. And of course you do got to read the situation. If they're obviously like grimacing in pain, be like, hey man, what's going on? Probably not the best way to start that conversation.
See, do you, I don't know, like I try to, that interaction piece I think can be some of the easiest things we do, and also some of the hardest things we do.
Oh yeah.
And I'm very, my natural bend is I'm very process oriented, which is one of the reasons I think I get along with Kramer so well, because she's very process oriented. And the brain. Yeah, just that organization and stuff like that. And the reading which patient like you need to be very very process oriented with, and you just like you need to go in there and you're like, I just need to get all this stuff done.
Yep.
We can joke later.
Yep.
But right now,
oh yeah,
like
I said,
I don't
reading
need to,
the situation.
Yeah,
exactly.
Yeah.
Like if you got stuff you got to get done, like let me do my work, and then once I get you stabilized, then I'll come back, check on you, and we can talk a little bit more and do the getting to know you kind of thing. Because I feel like that's an important part of the patient experience too. Even though we're just the emergency department nurses, you know, we start your care, so we kind of pave the road for everyone else.
Yeah, no, it's true. I hadn't thought about it like that, but yeah, that's true. I wonder I wonder how many patients will go up to the floor and just not be happy because of one of the experiences they have in the ER.
I totally can tell you right now
if that poisons their whole experience.
Mm-hmm. Now, if you get something like that, I also have seen, like, from working as the med tele tech or PCA, that again you can totally change that by having the right person come in and just kind of try and smooth things over and let you know, you know what, I get it. I'm sorry. That sounds like that was a terrible experience. I hope that I can make this experience much better for you, and just kind of work with that. And you can get that same thing when you're doing shift change. Maybe you had the previous nurse was just, you know, having an off day or grumpy or whatever, and then you come in,
or they were just completely overwhelmed,
and then your new face, and you know they're already angry, especially if they got to be transferred to another hospital or something like that, and be like, you know what, I hear what you're saying. That sucks. It really does, and you know it sucks for us too. But hopefully, while you're waiting to get over to the next hospital, I can try and make you stay as comfortable as possible. You know,
do you really say all that?
100%.
I need to be better about that.
I am all about trying to make them,
because I
smooth things over, because it's not their fault, it's not our fault, it's whatever situation is going on where we have to send them out, you know.
Because I don't consciously think about it that way. I mean, I think I do that, but I don't specifically say, you know, I want to make your experience better. I'm sorry that, you know, maybe I can change and improve your experience. Like, I don't say that. I mean, I think I do that.
It comes naturally to you, whereas like I at least like to let them know that I'm here for you. You know, because that's what we are. We're advocates for the patients, right? I want to go and make sure that I'm going above and beyond what needs to be done in order to help. I mean, obviously there's limitations as to what I can do. Obviously, no, I can't, you know, go upstairs, clean a bed, and be like, here you go, it's yours now. Now you don't have to leave. But or no, I'm sorry, I can't get you all the narcotics in the world to make you feel better. But I can do what I can do, and then that's the best I can do. Yeah. And that's kind of sounded weird to say.
Yeah, but no. But I think like specifically saying that we're like, you know, I'm sorry you've had a bad experience. I will do everything that I can, you know, or whatever you say.
It's about validating experience, or it's about validating feelings.
No,
I learned that stuff from my wife, actually. So my wife is a social worker, and she got her master's in social work, and she does a lot of therapy, and so she's like, I consider her my own personal therapist. So we do a lot of processing, and you know, when we don't have fights, we have discussions. Is basically what it is. And you know, because there's no resolve when we both get heated and start yelling at each other, because all it's going to do is create bad blood, and we're going to go to bed mad or something. So we sit down and we express, you know, this made me feel like this, well, this made me feel like this. And sometimes it can start getting a little heated, but it takes a second. We step back and be like, nope, I'm listening to what you have to say, and I'm sorry, you know, I didn't validate your feelings. I know you were just trying to vent about your situation, and maybe as it used maybe that my mom's personality that I have kind of came out, and I was a little colder than I meant to be. But I'm sorry. I will try next time to be more understanding and opening to your feelings. And sometimes all you want to hear is I'm sorry or you're right, kind of thing. To make
sounds like a bunch
better.
Of crap to me. I don't know.
That's all that therapy.
That's a therapy mumbo jumbo therapeutic communication.
Yeah.
No, I think that's super valid. No, I like that. I think I'm gonna have to start incorporating that more. Because I think just saying it.
Mm-hmm.
I mean, I do it. I mean, I think I do that.
Mm-hmm.
But if I don't say it,
they don't always
always recognize that that's what they're getting.
Mm-hmm.
Oh, that's
game changer.
It could be.
Mm-hmm.
It totally could be.
Try it this weekend. I guarantee you we're gonna have to do it.
Oh yeah. Does it have to be this weekend? I
Yeah.
mean, I got a lot of stuff going on. I just
Don't you call in.
So, hey, can we do this again? Can we?
Totally.
Yeah, awesome. That'd be fun. So let's end it there, guys. I appreciate you so much coming out. We spent
Absolutely.
a lot.
No,
I mean,
thank
it
you.
was a longer show. So this is gonna get split up.
Weird.
And probably, yeah. So that'll have to go into the introduction at the very, very beginning. That's a lot of audio. So thank you. I mean seriously, thank you. Again, this is such a great processing tool for me. And I think using, because it can feel so much like an echo chamber.
Mm-hmm.
Here, because it's the same ideas, and I talk to a lot of different nurses. I talk to, in this role,
Mm-hmm.
and try to get.
It's different when you're just sitting here talking to yourself. Well, not talking to yourself, but talking to an audience, but in the process of creating the content.
But I think it validates. I mean, hearing stuff that's familiar, and stuff that, like, what you say, like, sounds exactly with exactly what I say, stated in a different way,
mm-hmm.
and it validates some of the things that I talk about in the show, and I think further validates that I'm heading in the right direction.
Yep.
I don't have all the answers, but I'm heading in the right direction, and I haven't completely gone off the rails yet. And if I do, then it's time to hand off the podcast to somebody else. But I haven't gone off the rails yet, so that's good.
It's always good.
But this was a lot of fun.
Absolutely.
I think we need, if you're open to it, I'd like to have it. I'd like to have you back.
Absolutely.
See, I'm already done. Maybe I should give it up now.
Yeah. Womp womp.
Womp womp. So yeah, please come back. And thank you.
Absolutely.
All right.
Nursing Student Ground, this is Real Talk 6, ready for taxi with Romeo Papa Hotel, downwind departure. Roger, Nursing Student Ground, taxi to 31 right via Zulu. Nursing students, do you want to become an RN and think someday you'd like to be a flight nurse? How can you make this happen? What's the best flight path to make this dream, inside the dream of being an RN, a reality? If this has any interest for you, you should go out and buy the Flight Nurse Bible, a field guide to awesomeness by Robert P. Harris, BSN, RN, CFRN, CTRN, TCRN, CEN, CPEN, CNPT, CCRN. Here's Nurse Rob reading a selection from his book. You can also hear the full two-part interview with Nurse Rob from Season 4, Episodes 2.1 and 2.2, published in December 2019 on the Real Talk School of Nursing podcast.
There are billions and billions of people on this beautiful blue planet, and we are all spinning through space together for the entire term of our short lives. These facts should not depress you or make you feel small. These facts should inspire and empower you to look around the world and see the many ways you can make a positive impact with your existence. If there is a greater purpose to life, it must be to serve one another passionately and alleviate suffering. We must also attempt to live as intelligently, courageously, and joyfully as possible. Semper Fi, blue skies, Vaya sin Dios. Oh, and one more thing, no matter what you do not walk into a tail rotor.
Nurse Rob has a great preview on the book on Amazon.com, and you can connect with him directly on LinkedIn by searching for Robert P. Harris. Check him out. Check flight path.
You're listening to the Real Talk School of Nursing podcast.
thanks to everybody for joining us for part 2 of the interview with Nurse Matt. Thank you so much to Matt for coming out, and I hope you had a good time, and I can't wait till the next time we can get together and record another show. So let's talk about the giveaway. So I'm going to take entries on the first of the 3 items until March 31st. So I'm going to take entries until March 31st for the Yeti Hopper Flip 8, the Yeti Hopper Flip 12, both soft-sided coolers, and then the Yeti Camino bag. And we're going to do this in a first-come, first-served format. So if you get your name drawn in this round, you choose your prize. You get to choose one of those the 2 coolers in the bag, and you can choose which one you want, and I will send it out to you. So if you're on Facebook and Instagram, I'm trying to make this as simple as possible. Obviously, like or follow the page or the feed, the Instagram feed. Share the episode post with one of the Yeti cooler picks in your story. Share the episode post with one of the Yeti cooler picks in your feed. And I'm doing that so it sticks around, because the story only sticks around for like 48 hours, and these are really expensive. And you know, help me justify this a little bit, right? You know, if you want to delete the post so you're not screwing up your ambiance, you know, of your feed, fine, okay. But for this month, you know, for the purposes of the giveaway, please share the episode post with one of the Yeti cooler picks in your feed. Make sure to tag us at Real Talk Nursing and use the hashtag Real Talk Nursing. And lastly, tag 2 friends in the original post. And or I suppose you could also do it in your own post, and that'd be fine too. But I would really appreciate it. These things are awesome. I carry my Yeti cup every day. I carry my Real Talk School of Nursing Yeti cooler every day. And these things are absolutely awesome to have. They keep my food cold, because, I mean, let's face it. If you're a nursing student, or if you are a nurse and you're listening to this program, you know as well as I do that you don't get to go off to the break room in the middle of the shift and go sit down and eat. You come with your cooler to the nurse's station, you know, or a little lunch bag or whatever, and you stuff your face with food that you can get, you know, because that's the only time you have. And this, you know, COVID-19 stuff is not making it any easier to take breaks, because I don't know about you guys, but it takes so much longer to do cares and to make sure that, you know, we're sterilizing everything, cleaning the rooms, you know, takes so much longer. The airborne precautions, we're doing like airborne and contact precautions and all that kind of stuff. So it takes even longer to perform normal, easy patient cares. And it should, but that creates bigger problems when it comes to taking care of yourself. And you know, there's just not enough time in the day to separate yourself and go take a break, you know. And we're also working short. Most of the time we're not plussed up with nurses or techs, and so we just don't have the personnel we need where we can break people either. So having this cooler and having food available to me as a nurse, and having my cup available that I wash every day, by the way, but having all of that stuff available just makes life, you know, in the shift so much easier. It makes it so much nicer, and it keeps the food cold. And, you know, just a little ice block, whether it's a Yeti one, or not an ice block, but a whatever you want to call them, a freeze pack. You know, you throw one of those things in there, and it keeps my food at least refrigerator temperature the whole time, and it's awesome. And, you know, I can put ice and water in my Real Talk School of Nursing Yeti cup, and there's still ice in it at the end of the shift, which is really, really nice. So it's worth it. It's worth your time to to share the post. It's worth your time to enter in to win. These things are awesome, and I bought these because I think they're awesome, and I want to share them with you. So let's go over the rules again, okay? I'm going to take entries on until March 31st, and you get to choose, if your name is drawn, you get to choose between the Yeti Hopper Flip 8, the Yeti Hopper Flip 12, and the Yeti Camino bag. So if you're on Facebook and Instagram or Twitter, like and follow the feed, like and follow the page, share the episode post with one of the Yeti Cooler picks in your story, share the episode post with one of the Yeti Cooler picks in your feed, tag us at Real Talk Nursing, use the hashtag Real Talk Nursing, and tag 2 friends either in your post or on the original post, with us. So again, thank you guys so much. I so appreciate your continual listenership, and thank you so much for those of you who have gone over to the Patreon page. You can support us directly at www.patreon.com/realtalknursing. And I'm so excited for the things that are coming up. I'm so excited for projects that I have coming up and what the next year looks like, because I'm approaching 2 years. This year will be 2 years that I've had the show, and it's it's a long time for a show like that, for like this to exist, and the previous hosts, they did a great job getting it off the floor, and I've tried to grow this thing as much as possible and deliver really good content, both in social media and in the podcast. Hopefully you agree. Maybe you don't, but we're increasing listenership, and again, if you're listening to this, thank you so much for taking the time to do this. So just bear with me, guys. Bear with me. There's so much more to do. There are so many great projects that are upcoming, and I really want you to be there with me. Thank you so much for sharing the post. Thank you for sharing the episodes with younger classmen, with younger cohorts, with young nurses, and just, you guys are awesome, and I so appreciate you. So I'll end the show there. We'll move on, and I don't know if I'm going to get another episode in this month, but maybe I will. So let's just go with it there, and maybe I'll see you in a couple weeks. If not, I'll see you in April. Love you guys. Talk to you soon. This Real Talk School of Nursing podcast is a Real Talk production. This podcast is dedicated in loving memory of my brother, First Lieutenant Justin Smith. Blood and Steel.
Sic semper tyrannis, facta non verba.
Good night, Steve Cannon. Wherever you are. Annyeong, Kasayo. Now you go home.
If you like the show, you can support us directly at www.patreon.com/realtalknursing and gain benefits such as early content, shout-outs, special swag, and more. You should write in to realtalknursing@gmail.com or use Facebook Messenger, or contact us through Instagram or Twitter to share your experiences, ask questions, and give your feedback. Thank you for supporting our friends, affiliates, and sponsors. Thank you as well to everyone who started following us on Instagram, Twitter, and Facebook. More listeners means more and better shows. Make sure to share the show with your classmates, and especially those underclassmen. Let's give a hand up to those who are coming behind us. If you're new, welcome to our community of fun, engaged, and supportive nursing students and nurses. Don't forget to reach out and tell us if you have any announcements for graduations, good grades, difficult tests, friends you want to congratulate, and your announcement will be featured on our show. If you like the show, the Real Talk School of Nursing podcast is available on iTunes, Google Play, iHeartRadio, Libsyn Web Player, Stitcher, YouTube, Spotify, and SoundCloud. So, go to wherever you download podcasts, subscribe, rate us, review us, write into the show, and smash that subscribe button. Remember, leave only 5-star reviews, because that's the only ratings that count to get us noticed by more nursing students.
The Real Talk School of Nursing podcast is a holy moly, I can't believe you're still listening to this podcast.